I'm a native of Knoxville, Tennessee. It's always good to be back in the South. I came down today from New York. I work at New York University. I'm a primary care physician. I have been credentialed, less so now with young kids, but for the last decade or more, I worked quite a bit in the New York City jails as a doc, kind of urgent care, primary care doc. That's how I got to kind of really know incarcerated populations. And then in primary care, I work mainly at Bellevue Hospital. That's a big public hospital in East Midtown or downtown New York. So our clients are mostly uninsured, Medicaid, and we've done a lot in primary care with opiate and alcohol treatment, along with smoking cessation. So I grew up in the era of buprenorphine prescribing. Now we've done a lot with Vivitrol, or extended release naltrexone. And we've done all that mostly where I work and what I've researched is primary care settings. So less so the standalone licensed specialty drug treatment clinic, and I'm more working in kind of the primary care area, which we think is a big part of the national response to overdose and opiate problems, as well as kind of chronic high rates of alcohol problems, is your primary care doctor or nurse or physician assistants, you could have a whole team here, needs to be able to handle those diagnoses in a regular general medical setting, as opposed to sending you off to somewhere else where we know people are unlikely to make that referral, and it's just not very helpful if you show up asking for help and you're told this isn't the place to get it. So part of what my agenda is not specific to criminal justice, but I think it has a lot of important implications for criminal justice, which is just to make, for instance, opiate medication treatment broadly more available in any old health practice, and that would just lower the barriers and get more people into treatment, and then we'd have fewer people who are criminal justice involved in the first place. And part of what I'll show you is that when we have worked with, say, getting someone on suboxone at Rikers Island, that's a New York City jail, getting them to Bellevue, the public hospital, as soon as they get out, to take over and keep prescribing that. The whole goal is no heroin use, don't go back to jail, be well, be functional, and stay on this medication. We found that works not 100% of the time, of course, but it works as well in that kind of referral source as it does in other streams of patients that are coming to the same clinic. So we have found that treating people with criminal justice issues doesn't have to be anything much different than treating people who don't happen to have parole, probation, or just got out of jail. And you can treat them in the same kind of non-specialized program, and as long as you're using interventions that are evidence-based, and a lot of this talk is about MAT and the medications, you're going to see good outcomes overall, on average. And another important point there is kind of, on average, the stuff we're talking about is evidence-based, means that on average it works better than placebo or some other usual care intervention. The whole premise of kind of science and then applied science in terms of what we should deliver in terms of community treatment does not mean that we're going to fix everybody. It doesn't mean that everyone's going to have a happy, functional life after they've been traumatized and they're schizophrenic and they are crack cocaine addicted and they use a lot of heroin. But on average, if we apply kind of evidence-based approaches, that population of folks in your county or your state are going to do much better overall. And that's going to mean a lot of good things kind of flowing throughout the city or county or state. You're going to save money. You're going to have less kids in foster care. You can maybe close a prison or two statewide and move things from, again, the kind of punitive sanction zone into, kind of health care. And so whenever you get a speaker like me, the whole thing is, addiction is a disease. It can be understood as a kind of chronic maladaptive behavioral and physical process that leaves people in a state of kind of involuntarily having to use illegal or legal substances that still are causing great harm and cause public safety disruption and problems. And it's never made sense, really, the war on drugs, if drugs are kind of a symptom of mental illness or just a thing that a lot of us are going to have a problem with in our lifetime. And so here again is a speaker saying, let's move into a new era where we start to treat things sensibly, economically, and kind of with the science base. All right. I get grants from the federal government, principally NIDA, drug abuse, as well as NIAAA, which is the Alcohol Institute. We do try and get medications from manufacturers for our trials. They otherwise tend to be expensive. If we can get them donated, that's great. It saves ultimately the federal government a lot of money. I don't otherwise work for pharma or get paid for that type of consultant. If I was lecturing like an intern class who just showed up at the hospital to begin their life as doctors, this is what we try to get them to know. This is really what we think is the evidence-based. This isn't really new, but some of the stuff I'll talk about today comes back to this. We should talk to everybody about smoking. We should tell everybody don't smoke. And if they're smoking, we should help them quit with nicotine replacement therapy. That's gum, patch, lozenge, inhaler, e-cigarettes. Whatever you want to do, just don't smoke. You can stay on nicotine the rest of your life. Just switch to e-cigarettes, Nicorette, patches, lozenges, non-vaporized inhalers, all this stuff. There's a whole world of safe nicotine out there, and that is a key intervention we should be delivering to the entire teenage to adult world. And that's a key core thing in addiction. It's often overlooked, but smoking, by the way, is an addiction. And the principle of nicotine replacement therapy is really not unlike methadone, suboxone, or in a way how we use naltrexone. The whole point is that you're going to use some substances. We're not trying to make you necessarily clean and sober for the rest of your life. How about caffeine? Anyone had caffeine today? Yeah, we all have, right? We could be in a certain part of the world of society where we declared caffeine to be illegal, much or super bad and unhealthy, much the way we think of cigarettes. It turns out caffeine isn't that bad and probably is actually really healthy. If you look at some recent studies, the more coffee you drink, the longer you live. So keep on your 5 cups a day of coffee, et cetera, et cetera. Now let's talk about cigarettes. Cigarettes, not healthy whatsoever, and you can throw in smokeless tobacco there too. But it's not really the nicotine. Nicotine itself is a little like caffeine. It's a mild stimulant. It is addictive. You can get hooked on nicotine for sure, and we all know this. But it's a delivery system that is out of whack here. It's the smoking incinerated tobacco organic matter that is what gives you a lot of carbon monoxide, a lot of volatile chemicals that'll give you lung cancer, heart disease, et cetera, et cetera. The nicotine itself is kind of the hook, but much like caffeine, you could probably spend your whole life on doses of nicotine and not have any trouble health-wise. And then if you think of alcohol, opiates, and other stuff, alcohol and opiates are kind of in the middle there. You probably could actually have a long, healthy life on opiates. And we see people do this in treatment, and we know some people do it through chronic pain diagnoses where they're actually on opiates forever and ever, and they're not getting off, but they actually do okay. We see people on suboxone, that's buprenorphine, the most popular buprenorphine product, but it is a trade name. I'll try and say mostly buprenorphine. But if I say suboxone, that means kind of everything that we call buprenorphine products. You could stay on that for the rest of your life and do perfectly fine. A little bit of alcohol you could do well with, and that's where we get to here. Alcohol is interestingly, non-drinkers compared to I drink 1 to 2 drinks a day. The 1 to 2 drink a day adult is actually healthier on average and lives longer and has less heart disease than the 0 drinker. But you got to keep it to 1 or 2 a day. The 4, 5, 6, 7 a day drinker on average does much worse than the first 2 groups. But it's an interesting thing. You could be on some alcohol for the rest of your life and do perfectly well and be super healthy and maybe even healthier than people who do not drink at all. With opiates, again, you could be on the right opiate for the rest of your life and do okay. So addiction isn't so much about like drugs bad, get off all drugs. It's more of a kind of nuanced thing, and our treatments can fall in kind of the middle there. And a lot of the stigma generated by something like methadone is that someone's staying on drugs. They're still on drugs, get them off drugs. But it's really just not, doesn't make any sense from kind of a kind of biomedical evidence-based standpoint. So we want to tell people not to drink too much. If they're drinking the right amount, then we pat them on the back and say good. You can talk to people about drinking too much, and it's been shown to be effective in terms of reducing their rates of drinking over time. We call that a brief intervention. SBIRT, you ever heard of SBIRT? I bet you have at a conference like this. SBIRT only works for tobacco and alcohol. That's one of your take-home, up-to-date science, cutting-edge stuff. I'm going to show you one SBIRT study in criminal justice, and it doesn't do anything. It's really just for smoking. Do you smoke? Don't smoke. Here's some Nicorette. And it's only for drinking. How much are you drinking? Oh, you're drinking 5 a night on average, but you have no other alcohol problems. Can you try and keep it to 2 a day on average? Okay, great. Let's follow up in 3 months. That's what works for alcohol. And then we have medications, as I've kind of already talked about several times, and I'll come back to that for a lot. And then you should treat withdrawal. When they show up in jail and they're in alcohol withdrawal, benzo withdrawal, opiate withdrawal, that should be treated, and we have good and safe ways to do that. You should prevent overdose. If somebody is blue and they probably injected heroin, they need fentanyl and they need oxygen. You can keep that body alive by breathing it. You could just do kind of CPR until they woke up. That, in theory, would work. Or you could deliver oxygen and a bunch of Narcan, and then they'll wake up quicker. We want to have things that help people engage in care. So if people know if they go to the ER over there, the docs always treat them like shit, and they call them junkies, and they try and kick them out of the ER. People are never going to go back to that emergency room, and that emergency room is no longer really effective at treating that county's opiate problem. And we see that, all in all, time and time again, and that's kind of the legacy in large part of kind of gold-plated healthcare and healthcare systems and the nice hospital. It generally has kind of never wanted to touch these populations, and we'd like to see that change, because you can help people with all their other stuff while you're trying to help the addiction. You can use things like needle exchanges that might fall under this bullet point. We're not going to get everybody to quit using drugs, particularly heroin, say this week, but we could get them to spread less hepatitis C around town and not give anyone else HIV, and that's the whole premise, kind of harm reduction. And then good counseling approaches. Here's where I was trying to go with my little cartoon. I don't think it really worked, but you can do a lot of great counseling, and that tends to happen in specialty settings. What I was trying to show here in the red box is that in criminal justice, we tend to see some like case management or a lot of AA, but you don't see a lot of other kind of evidence-based counseling. So the more you could build that in, the better. And then the more you can build in medications for these populations, the better. And that'll be largely the kind of theme and focus of this talk. So you want some cutting-edge data. You probably already heard about this, but the overdose epidemic is getting worse. Not better, worse. From 2016 to 2000, these slides, which you can barely see, go to 16. This is the overdose epidemic, deaths going up. This is a national map of where deaths are worse, same, or better than the national average. Alabama is coming in better, Tennessee worse, Georgia better, North Carolina equal, Florida worse, Louisiana worse, Mississippi and Arkansas a little bit better. So dead average is North Carolina, say. Alabama's a little better than average, and Tennessee is worse. The driver, if you could see the slide, which you can't, of overdose rates over the last 5 years has been fentanyl. Everybody heard that one? Yes, we've all heard this. Well, here's a slide that the CDC would show you to make that same point. The fentanyl contamination of the heroin supply has been a freaking disaster nationally, and it's been a little bit spread out regionally. This is, I believe it was originally, it's kind of like DEA street sample data, and it is looking at fentanyl or fentanyl analogs in both, I think, street buys and toxicologies of people who have overdosed, and it's looking at 10 states, and it showed a very, very high prevalence, I think from 2016, of fentanyl present in heroin supply and in overdoses. And it varied, like here's on the way left without much fentanyl. still with opiates on the street or a dead body that probably died from opiates, and not much fentanyl. That's Oklahoma. And then upper New England, Massachusetts, Rhode Island, but also Missouri, Ohio, seeing pretty much on average an overdose death there was associated with fentanyl or fentanyl-like analog. These are super, super potent opiates. They do have a use in human medicine. What's happened is that they can also be pretty easily manufactured illegally in a clandestine lab here in the United States, in Mexico, in China. That's kind of famously been one route for it in the last 5 years. And then you only need about this much in a FedEx box of fentanyl to, kill half of Birmingham in the next month. It's so potent that you then can cut it up, and it makes a good business sense. Your bag of heroin is now just a bunch of junk plus a little bit of heroin. A little bit of fentanyl. And it's just hard to control, though, a usual dose that will get me high and get me my fix, and a toxic dose that would send me over the edge, put me to sleep in a coma, have me stop breathing. That's how you get an opiate overdose. And fentanyl is just too dangerous to play around with, and yet it's kind of taken over the so-called heroin supply in the United States, and thus the overdose rates have just gotten worse and worse and worse. Here was a ESPERT trial. What I'm doing here is skipping around between a bunch of what we thought in a recent review I did with a colleague was a kind of high profile, pertinent to this audience, so most of these are criminal justice oriented or opiate overdose oriented studies that came out in the last year and a half that were kind of highly rated or otherwise important. This was one about ESPERT, and this is where I kind of go through the limits of just talking about drug use and recommending people use less drugs when they leave jail, and then follow them over time and see what happens to their drug use. This was a very well done study in Los Angeles County. It was, where did I put the pointer? All right, I'm going to walk out of here with this pointer. It was done in LA County, and it wound up screening a couple hundred people, and if you were a moderate risk drug user, you got their ESPERT intervention. And what happens when you do a big drug user ESPERT study is, what's the most commonly used illegal drug in the United States? Yes, it's marijuana. And how many people using marijuana have a severe marijuana use disorder? Just off the top of your head. Some do. Some people really have a marijuana problem, let's face it, and they really need to stop, and we need to help them do that. But a lot of, say, adults in LA County Jail use a lot of marijuana, and it's not the clearest, biggest problem in their life, you might say, and so they get put into this bin of moderate cannabis use, and then that becomes the target for the screening and beef intervention thing that this study is doing, and lo and behold, later on when they check on people, I think 6 months later in this study, how they were doing with drug use, nothing had changed if you had gotten kind of counseling specific around trying to reduce your drug use. In this case, a lot of the cases were marijuana use, versus people that had just gotten like a pamphlet saying, hey, don't use as much drugs are bad, or something like that. We really don't have much in terms of treatment for cannabis use disorder. And that might be okay because cannabis doesn't kill anybody. It can obviously present a lot of criminal justice difficulties, but things are changing fast, and they changed, like for this study, during the years it was being conducted. It was in California. If you went to the LA County Jail today and said, don't use dope because you might get put back in jail for smoking a lot of pot, and the answer would be, no, I won't, because we just legalized that. It's not med-mar anymore in California. It's completely legal there. And that's happening, of course, in a lot of states. I know it hadn't happened in Alabama or Tennessee, but it's just looking like marijuana, despite the current Attorney General, is just not going to be as big a law enforcement thing, state by state and on a national basis, as it ever has been. Medically speaking, we don't have any medications that help with marijuana in terms of reducing its use or really doing much for its withdrawal. We don't really have much in terms of counseling approaches, and this is an example of a negative study in terms of one type of counseling approach for marijuana. So if you want to know the kind of latest, greatest science on marijuana, is that we don't really know what we're doing. We're not really sure where all these state-by-state policies are going to take us. We are seemingly entering an era of more kind of pervasive, common, and legal, depending on what state you're in, use, so it's going to become kind of more the norm. Again, though, we're not seeing dead bodies pile up because of bong hits. So in terms of a public health threat, marijuana doesn't seem to pose one. And then there's some interesting signals that in the states that have legalized marijuana, they're seeing better overdose and other opiate outcomes. They're seeing fewer people using or misusing prescription opiates, if you can measure that in some of these databases, and they're seeing some declines in opiate overdose deaths across the board. It's not to say that marijuana has caused that, like in California versus Nebraska. That's the kind of state-by-state comparison you would do. But it's interesting to think about, and there may be a lot of energy in the future on the kind of NIH side into figuring out if marijuana is an effective pain intervention, particularly for chronic pain in this vast population that we would like to get off OxyContin and onto some non-narcotic or non-opiate-based chronic pain therapy. And you can do cannabis derivatives like cannabidiol, which are not themselves psychoactive. They're not really controlled substance, but they are derived from cannabis. And those kind of things can be put into kind of medical form, and that might become, if the studies bore this out, something to do for chronic pain. So that's kind of your cannabis update, and that's totally myself editorializing. I don't represent anything here other than, you know, my own kind of knowledge base and public speaking, but I'm otherwise not representing, when I say stuff like that, NYU or NIDA or anything like that. Here's one where we compared Vivitrol to suboxone. I'm using the trade names because those were the specific products that we looked at in this study. This was a big head-to-head study that wrapped up early last year and was published in November 17, and it compared folks coming into 8 detox units around the country. Closest one to Birmingham was either Columbus, Ohio, or Jacksonville, Florida. And we had one at my center in New York and southern Massachusetts, Albuquerque, Seattle, and Los Angeles. And it showed some interesting stuff. People showed up on a detox unit, so kind of a hospital or kind of your kind of county, you know, basically rehab. They would do a couple days of detox and then maybe stay for a week or two on the rehab, or in some cases, they would kind of go right back out to outpatient treatment. People signed up for this in pretty high rates and were all opiate users, mostly heroin. They wanted to flip a coin, or they agreed to do this. And they had to then either complete their detox and get on to naltrexone. That is extended-release naltrexone or Vivitrol. You have to be totally detoxed because it's an opposite. It's an opiate antagonist. And so to safely get on it for the first time, you need to be clear of opiates, and so your detox is done. Or they went to buprenorphine, and buprenorphine you can start immediately. In fact, we use it for detox. So it is itself a partial agonist, or it is a semi-synthetic opiate, and it helps relieve opiate withdrawal. And it's also routine to take someone on Monday using heroin, and by Tuesday I have them on buprenorphine, and they never got off opiates. And then we followed them over time for a relapse outcome, which was if people went back to using opiates regularly, meaning every day of the last week or on a consistent basis for 4 straight weeks. Or they were missing, and that would qualify as a relapse if we couldn't prove that you were doing well in terms of your self-report and your urine. When we look at the A, that's the slide on the left, this is everybody that flipped a coin and then was asked to get onto Vivitrol, that's the red line, or to suboxone, that's the blue line. And then it's looking out over 24 weeks or 6 months in terms of relapse-free survival. So if everybody got on drug and avoided ever using heroin again, these 2 lines would be straight at the top. They would just be a straight line that never went down. But that's not what happens in real life or in real treatment. People get out of the detox, and then some people are lost, some people are still using on top of the medication, some people quit the medications and are still using, so on and so forth. That's treatment. It turned out that it was easier to get people onto buprenorphine and there was an immediate separation of the two curves. It was much harder to get people to complete the detox and get that first dose of Vivitrol than it was to just put them right on buprenorphine. We kind of knew that would happen before, but we never had any studies showing what really the kind of percentage is, what proportion of people you can expect to do this, and how Vivitrol is going to compare to buprenorphine, which we knew a lot more about at the time we launched this study. And then they do about the same over time. If these curves kept going in different directions, you would say that during treatment there was also a big difference, which there could have been. But these slopes kind of start to run parallel. And then if you look at B, this is what we call the per protocol sample, where this is just everyone that got on one dose of either medication, and now they look very, very similar, and there's no difference actually statistically between these groups over time. So it was kind of a glass half full, half empty for people that like naltrexone, including the manufacturer of Vivitrol. It was definitely harder to get people on it, but in this very big study, once people were on it, it actually looked pretty good compared to a buprenorphine standard of care. And we were using suboxone film in this protocol, and Vivitrol was Vivitrol. It's the only form we have out there. In addition, there was a study done in Norway. Now you can think about this tonight, how much a Norwegian study applies to your population. But over in 5 sites in Norway, they kind of wanted to do the same study, and the government of Norway did it. So it was an unusual example of 2 studies in 2 different countries that were run independent of each other, although we talked along the way and we knew the people doing it in Norway. I'm sorry, if I didn't say that, I was part of the team that led the US study. The Norway team did a similar thing. They did a shorter study in a smaller amount of people, and they actually managed through just the way they did their protocols to get everybody, for the most part, 90% of people on both drugs. So there was no difference in the induction rate. We saw a substantial difference. And here, this is treatment retention over time, so it's not quite the same outcome in this curve, but the extended-release naltrexone group did a little bit better over time in terms of keeping people engaged and on treatment than did the buprenorphine. So it was a little bit of a switch or a flip, and probably just because of how things were done in Norway as opposed to how we did the US study. I'm not going to go into the gory details, but there were 2 studies that kind of pointed in one direction, that extended-release naltrexone actually is pretty good compared to a buprenorphine standard of care in terms of treatment retention and preventing opiate relapse in a community sample. These were not, they could have criminal justice issues, and we're going to look at, who did, who didn't, who's on parole, who wasn't, but it wasn't a study that was focused on criminal justice populations or flows of patients. It was all community volunteers, people that had showed up for treatment in the first place and then got involved in these 2 studies. More to come from the buprenorphine world. Have you heard of CAM 2038? That's a code name for one product going to be brought by a company called Braeburn to the FDA later this year. It's already been before the FDA. They asked for more data, maybe one new study. But this is a manufacturer that actually makes the Probafene buprenorphine implant. Anyone seen a patient implant of buprenorphine in their arm? We've had that product out for about 2 years now, and nobody seems to be using it. But the company keeps trying, and they got a new formulation that's a 30-day injectable or a once-a-week injectable buprenorphine. I show you this study because it's in the literature, and I could pull a graph for it. Perhaps more importantly, there's another product from Indivior. They are the manufacturers of suboxone film. They also came to market, and they actually have approved a product as of March of 18, so just recently, that is also a once-a-month shot. You get it in your belly. It's going to be delivered in a healthcare setting. A nurse or doctor or whatever is going to give it to you. And it's a month's worth of buprenorphine. And then you maintain, just like you should be doing anyway, on your buprenorphine, and then you come back in a month and get the next shot. This is the same logic that was applied to naltrexone in terms of Vivitrol and extended-release naltrexone. We're now going to have 30-day injectable, long-acting formulations of buprenorphine. I think it's great. I think all the kind of industry activity in this area is wonderful. I think we need, the Fortune 500 pharma to get involved with our people and try and prevent overdoses just like the next citizen. So I'm all for it, although others, in my field, I think are more skeptical of pharma and their motives and all that kind of stuff. But these new products should usher in a kind of buprenorphine age 3.0 or something like that, where we have even more ways of delivering it. And it'll be interesting how it's used and if it helps the harder to treat population. So people we want to do well on buprenorphine, they've given it a go, but they're really struggling. They can't take it every day. They keep losing their pills. They may be selling their pills, blah, blah, blah. We've all heard of some cases like that in terms of suboxone patients, and this would be one way to maybe improve on that if people would sign up for a once-a-month shot. You had a question? The question was what the cost will be of injectable buprenorphine. I can tell you because we're trying to do a study with it in some jails, including New York and a couple others, and we're trying to get them to give it to us, and so far they haven't. And we're otherwise, if we have to go on the market now and buy it, Supplicate is the one product out there. It's $1,500 a shot, which is astonishingly high. And can you imagine someone on that? You want them on it year after year after year in theory. So let's do a year. That's going to be $18,000. Now, let me tell you what a year of HIV triple therapy is, or let me tell you what a year of Cymbalta, Celexa, and some biologic for your rheumatoid arthritis is. All these fancy grade A branded specialty medications in infectious disease, in cancer, in behavioral health, and blah, 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 they all are super expensive. So the answer then to our people is Medicaid and public sector insurance or other kind of subsidies. Nobody can afford these meds when they come out of Rikers Island. They have to, people have zero money. That's the whole problem in their life. They're completely destitute and chronically so, and they have not worked for a while and blah, blah, blah. There's no resources, and so it has to be provided just like really any other kind of public health or chronic disease therapy if a population is otherwise underserved and in kind of public sector. Did that answer your question? We'll see. We don't know about the Medicaid question. Will the state of Alabama Medicaid pick it up quickly? Probably not. Will the state of New York Medicaid pick it up? Probably a little quicker than Alabama, just in terms of how New York State has kind of adopted these medications. It's been a little more kind of generous. And it's going to vary, all those formularies vary state by state, just as they do now for suboxone, for instance, or Vivitrol. All right, the point of this study was really just to talk about injectable buprenorphine, but the study itself was showing on these doses, it blocks the effects of hydromorphone that's dilaudid. They do these studies by bringing people into a laboratory, in this case at, I think, Columbia and University of Kentucky in Lexington. Somebody's already got an opiate problem, they sign consent, they live in the lab for like kind of being in the hospital for 3 or 4 weeks, and they will provide them the new treatment, they'll give them an injection, and then they'll start giving them dilaudid and have people rate, do you feel high? Would you have $10 or the next shot of Dilaudid? And you do these kind of experiments where you come up with if people are really kind of feeling the effects. And what this study shows is that it was a significant and expected blockade and long-lasting blockade of these usual opiate effects if they had been treated with the injectable buprenorphine. Oh, here you go. Here's Supplicate. So Supplicate, that's a brand name. We're not supposed to ever say brand names, but that's what we're talking about. It's injectable, long-acting buprenorphine. It's a 30-day syringe. It comes pre-filled. It is a narcotic, so you couldn't just like ship it to, the patient's home and have them do it themselves. It's going to, just go in the belly. That's where we do a lot of subcutaneous injectables. Vivitrol is a big intramuscular shot in the butt. This one's going to be a shot in the belly. And this is the Indivior data versus placebo. They actually did a study of opiate users who wanted treatment and were willing to randomize to 2 different doses of the new thing, Supplicate, once-a-month buprenorphine, or placebo, and they are looking at opiate-free weeks over time. If you have 100% opiate-free weeks, that means you did the whole study, grade A, you never used, your urine was always clean. With the placebo arm, almost no one can do that, and you get variations of it on the buprenorphine product. So far, it's consistent with what we expect with sublingual buprenorphine. We have no data so far showing that it's better than sublingual buprenorphine. But that is kind of the promise or the thought process, that if it's now a 30-day thing and it's in your body for the whole day, you don't have to voluntarily choose to take it once or twice a day, however you're taking your suboxone, and therefore it's going to be wildly better. We don't have any science so far or head-to-head studies that show it's any better than just giving somebody a generic buprenorphine naloxone tablets. Well, I expect to see some of those studies, but for now, if anybody says they know it's going to be better, I would say prove it to me, or where's your studies, and then we'll see. All right, this is, wow. Oh yeah, this was a great one. So anyone heard of this one? So Rhode Island sent a letter to JAMA Psychiatry, and they said, hey, we did something great, and here are the results. This is how this one went down. This was Rhode Island's unified state prison jail system. Probably not the case in Alabama. There's a municipal jail here in Birmingham, right? And then there's a state prison system. There's not a kind of one holistic system. Anyway, Rhode Island, small state, a couple other examples of this in smaller states like Delaware, Connecticut. The jail prison is kind of the same thing, and they kind of said, hey, we're having this horrible overdose crisis, and Rhode Island really has had a terrible per capita heroin and fentanyl problem. We're going to now offer whatever people want in terms of methadone, buprenorphine, or naltrexone, particularly to the short-stay jail, high-turnover population. And we're going to hopefully have an impact on the whole state's overdose rates. And they, in fact, think that they showed something like that. I again apologize if you can't read any of these slides, but what this study showed, JAMA Psychiatry, 2018, Tracy Green is the lead author, that when they had their new kind of pro-MAT, anybody can get whatever they want in terms of meds when they're leaving, and we'll help them get treatment when they get out with the right community providers. The overdose rates came down substantially. In terms of the whole state's rates, I think came down a little bit. But when they looked at the deaths, and then they looked at if dead body was dead body in jail in Rhode Island in the last like 6 to 12 months, fewer and fewer of the actual overdose victims had a recent previous incarceration. And so that's the kind of logic they use to say this is probably a really good thing to do. And no doubt it is. I don't think their methods were foolproof, or it's not something that isn't easy to pick holes in, because it's not a randomized control trial that they did or anything like that. But a strong signal that expanding, particularly in a jail setting, methadone, buprenorphine, naltrexone, could have big public health effects. That's exactly what they were going for. Probably a little better done study with more power, and that just means basically more people in the study, so the statistics get a little finer and more kind of reliable, was a United Kingdom study. It's looking at prisoners leaving on or not on mostly methadone and some buprenorphine throughout England, mostly. Other parts of the United Kingdom, mostly England, not Ireland. And it showed that the rate of, the survival was highest among the group that had been exposed, as they call it in this slide, to opiate substitution therapy. And this was the usual route of people on the lower edge that had not left prison on one of the two medications, and they did worse in terms of survival and overdose-related survival. They didn't find that those were long-lasting effects. They found it was particularly meaningful and pronounced in the first 4 weeks out. And that goes back to a lot of what we know from US data, that the first week out is the worst. You get out, you got no tolerance, you're stressed out, it's even crazier getting out than it was probably going in. You have a party and now you're dead. That is what we see over and over and over again when people leave controlled environments and are back on the street. Probably that risk lessens a little bit each week, but you could say the first week is the worst, you can say the first month is the worst, you can say the first year is the worst, all getting back to these first couple weeks and months out. particularly after long-term incarceration, but also applies to jails where people probably weren't there for even very long. But they were probably there long enough to lower their tolerance and jack up their cravings and stress level. And as soon as they hit the street, they probably overdo it. That's a very common story. And they just, without an opiate tolerance, if overdoing it means going back to a bunch of opiates, you're a setup for an overdose, particularly now that there's all this fentanyl in the heroin supply. All right, so those lead up to this messaging. This is not a study. This is my own little pie chart. It's showing people getting no treatment over the course of the year, and they're heroin users. You can expect over the last 10 years about 1 to 2 out of 100 people to be dead in that same year. Pretty high death rates, particularly because these are generally young or middle-aged populations we're talking about, who otherwise really should be dying of no other reason. But that's what overdoses have gotten us. Now we do detox, or say we put them in jail for a while, or we drug court them, but it's a lot of counseling. It's not a lot of medications. That probably is effective compared to doing nothing. And it probably saves some lives and lowers the death rate to maybe like 1 out of 100 over the course of a year. How about that one? And what I'm showing in my little pie is the slice got bigger in terms of people that actually look really good 12 months later because of the drug court involvement, because of all the counseling, or maybe just by luck or their own kind of internal strength. They got out a year after some kind of detox and are sober. They're not using opiates, say. They're opiate-free. And then you take, do all you want in terms of counseling, supervision, mandates, sanctions, blah, blah, blah. But now we're going to add medications, and it could be methadone, buprenorphine, or extended-release naltrexone. And now probably about half, maybe not quite, it really depends on the study you look at, are actually looking pretty good in terms of usually not using any dope on a weekly or daily basis. A lot of them are totally off it, and they've really kind of looked like a miracle has occurred, and they're new people doing new things and better things. And the death rate is probably about a quarter or a third of what it used to be. So again, you're not saving everybody with methadone or buprenorphine or naltrexone, but the data that keeps coming in, and what we've known really for like 20, 30, 40 years, particularly in the case of methadone, is that people really do well on average, long term. They should probably stay on these medications long term on average. And if you want to go to Southern Ohio and have fewer people die this year, you really need to look at if we're prescribing enough methadone, buprenorphine, or naltrexone. If we're not, and there's a bunch of fentanyl out there, and we haven't completely modernized our economy and elementary schools and foster care system and all that kind of stuff, which probably goes along with some national solution to the opiate epidemic, you're just not going to move the needle on these death rates or this kind of public health problem. Here's a study that I did with my team, so I have to include it in every slide deck. This came out in 2015. We did it kind of like 2012, 13, 14. It was only in about 35 people. This was the Vivitrol side. This was the didn't get any medications side. And everybody's leaving jail after this first column. The first column's all blue because they're sitting in jail. They qualify for a naltrexone study. This was a group of people who were not on my jail's methadone program. We have a big one, but not everybody signed up for it. They weren't on suboxone. They said they weren't really interested in that stuff. They were just kind of going to leave and, hope things went okay, or I'm going to leave and actually go back to using. That's what I'm going to do. But we talked them into a research study, and half of them got naltrexone and half of them did it. On the jail side, I'll tell you, if everyone's already detoxed, you can do Vivitrol that day. There's no waiting for people to get ready for a shot of naltrexone. They can take it immediately if they have a negative urine they say they haven't been using, and they've been in jail now for a couple of weeks or months. They're going to already basically be detoxed. And then they did better. They had more blue boxes, which meant they came in on a weekly basis and gave us a urine that was negative, as opposed to the usual history of heroin in New York City leaving jail. The majority either were kind of missing or back on heroin to some degree. Some every single time we looked at them immediately. Others, it took a little longer to get there. And it was not a huge study again, but it was a pretty clear signal that this kind of Vivitrol jail to community model at least cools people off in that first month or two out. It's probably not going to change everybody's life long term. There's some concern that people just don't stay on it long enough, and I share those concerns, and we need more research, and we're doing a bigger version of the study that lasts longer to see really can we keep people on it for kind of 6 months or longer as they leave. But not unique to naltrexone, we've done similar studies with buprenorphine and methadone that show similar stuff. Again, you don't get everybody into the right box, but you get a lot more people than you would otherwise if you're offering these medications as routine care as part of reentry. I'm going to skip that. Here's a kind of bread and butter thing about all the medications, but I don't think we need to, this isn't so much new science as the usual MAT lecture that you've already had like 15 times, and we do want to leave time for questions. So why don't I stop here? I'm going to keep glancing at my slides, but do we have any questions in terms of this amazing new science that we just covered, but addiction treatment principles in general, neurobiology, and how it all applies to these populations in our job? Yes, ma'am.
We're a state that has legalized marijuana, and so a lot of our community court participants use marijuana, and that's fine. So what would I be looking for in the event of a marijuana withdrawal? What are the symptoms? What does that look like, and how would that hurt someone?
Right, and what state are you in? Oregon, so Oregon legal pot now. Yeah, it's a great question. So what do we do now with clients who have it in their system? Right now their UTOXs are positive, but it's legal, so the sanctions probably have to get lower, right? And then what does it mean like long-term kind of to them as cannabis users, and how will it affect their health? Every program and every drug court and every kind of jurisdiction has to solve that one on their own. I'll tell you, the evidence in opiate treatment is that people do fine on whatever opiate treatment you're studying, even as they do cannabis. So the fact that someone is using cannabis while on naltrexone, say, is not that big a deal. As a treatment provider, I don't work in a drug court setting, or I'm not working for the parole division or anything like that. We're just treating patients as we see fit in a primary care clinic. A lot of them are justice involved or just came out of jail. We don't spend a lot of energy combating cannabis use in a treatment population where their primary problem is opiates or cocaine or schizophrenia and homelessness and all that stuff. So it winds up pretty far down the problem list. And I can't say for a fact that it's hurting people, and there may be some signals that maybe it keeps people more engaged in treatment or more doing just as well on their medications in terms of the opiate outcomes. Now, people can be overdoing it and on a daily basis and really have a kind of cannabis dependency, you might call it, kind of thinking about like a bad alcoholic. And there is a known kind of withdrawal syndrome with cannabis, and people are kind of agitated or fatigued, or it's kind of short or it's long. It's really kind of undefined, but people can really feel worse if the cannabis has stopped abruptly. But we don't have like great treatments for that. And in the usual course of business, I think people generally just keep using cannabis. And so in Oregon, unless there's some penalty within a particular program, like at veterans hospitals, it's a bigger deal because that's a federal system, so it doesn't matter if in your Oregon, Colorado, or New York, you're really under one federal system. And there, like outpatient treatment with buprenorphine or methadone, it's a much bigger deal if you're also using cannabis, because that can threaten your access to treatment in general. But that is, that's really kind of an administrative decision and not really based on great evidence about who does better or worse in treatment.
So Josh, we have a couple of questions over here.
Yes, please. Sir. Thank you.
What can you tell us about any advances made in the law synthetic cannabinoids like K2?
And would you repeat the question?
Yeah, so what about K2 spice? Those things are nasty. They it's a little bit like the fentanyl story. We're not sure what goes into a batch. There's not really a control of the dose, and these are cannabinoid-like products that are not themselves cannabis. So they hit the cannabinoid system. CB1 and CB2 are the big cannabinoid receptors that are where kind of pot does its work. And these hit that too, but then they can be much more severe in terms of their overall effects in doing so. And they can create psychosis, they can create like seizure, they can create real cardiometabolic dysfunction. We've seen deaths, and of course we've seen, a lot of just kind of zombie type stuff at the homeless shelter because everybody had a horrible batch of K2 that night or something like that. It's back to like bath salts, fentanyl stuff. It's hard to regulate. It's easy to make a new chemical that's slightly different from the old chemical. The DEA just outlawed the old chemical, but now we made 3 new chemicals that are very similar and are technically legal until the DEA gets around to outlawing them. And we can spray them on some cardboard and shred that up and put them in a little, potpourri thing and sell them at the head shop or the truck shop or the bodega, and that's your spice K2. So we haven't seen that become a worse and worse and worse problem. There's probably a limited appeal, frankly, to the general public of these products, and they're not physically addicting like opiates are. Or even alcohol or cigarettes. So one of the principles of who gets addicted and who doesn't, it does depend on the drug, and it depends on the body's capability of getting tolerant and then having a withdrawal syndrome. And so it's 100%. That's actually my next slide. People will all get addicted to opiates. If I gave you all enough opiates for couple days or weeks, you would all be hooked on opiates. No one could avoid this. This is how opiates work in all of our brains. This slide doesn't exactly say that, but I thought it was going to. No other substance is quite like that. Xanax doesn't do that to all of us. Alcohol doesn't do it to all of us. Nicotine doesn't do it to all of us. I couldn't stick you in a Nicorette gum machine for 3 weeks and have all of you be addicted to nicotine. It wouldn't work. Some of you would be, but not all of you. But we could do that with opiates. And that's a very unique and problematic thing about opiates. Everyone will get hooked on it for a while, and then this withdrawal is horrible. Everybody knows kicking dope is terrible, and it really is. It's psychically and emotionally and sleep-wise and pain-wise and poopy-wise. It's a terrible, terrible thing. No one can get through it. And that would happen to all of you. If I put you in my opiate machine for a week and then popped you out and didn't give you any more opiates, you would all have horrible opiate withdrawal. But with like K2 Spice, people do use it. It's legal, or it's cheaper sometimes than buying marijuana. People are really just trying to experience, probably, rather than get psychotic, they're trying to just have a cannabis type high. And then it goes south on them, and those are the bad cases that we've seen. But they don't then necessarily want to use it over and over and over and over again. Same thing with bath salts and these other kind of truck stop drugs. They're not great drugs, and they don't produce a tolerant kind of and then withdrawal cycle like opiates do, and so they have not become a kind of public health problem. But in pockets, and we've had a big problem with it in our immediately arrested, but the dude's mental status is totally, we can't tell what's going on with this guy. Did he have a stroke? Is he having a seizure? Is he in withdrawal? And it turns out to be K2 related. We've had a lot of trouble in our EDs and homeless shelters with it in New York City.
So Josh,
but we haven't seen it become a mass problem. More questions?
Yeah, we have time for one more quick question.
Okay, you mentioned earlier about evidence-based counseling, and I'm not sure what that would look like.
Yeah, so pep talks, your run-of-the-mill AA meeting probably is not delivering a really kind of well-studied, well-thought-out counseling strategy. CBT, cognitive behavioral therapy, motivational enhancement therapy, often called MET, post-traumatic stress kind of exposure therapy. These are all things that you need a degree for the most part, but that are accessible counseling approaches to professional counselors or health professionals or people kind of in community justice, social work kind of stuff. But it's it's a specific kind of approach and a way to kind of use the 30 to 60-minute interview with kind of certain goals in mind and certain rules of the road. And cognitive behavioral therapy is the most popular version of that. It's kind of the foundation for specialty drug treatment counseling. It has to do with kind of relearning kind of how to handle stress and triggers. And it also overlaps with motivational interviewing and kind of motivational enhancement therapy, where you're trying to seize on the resources and the motivations the person does have to try and change behavior. But that's different than just sitting down with someone who, you know, like your parole officer. Does a parole officer deliver much in the way of evidence-based counseling? Typically, no. You know, so that's the distinction I'm making. And for the most part, when a survey is done in criminal justice, does your program, you know, does your jail deliver any services or treatments for addiction? Often the boxes check that yes, and it's a bunch of counseling, and that might be some AA groups that go on throughout the week, or some kind of like discharge planning, but it usually does not amount to really kind of good professional grade evidence-based counseling.
Right.
More questions? We're done? We're at time? All right, we're going to wrap it up. Thank you very much.